All right, good morning, everyone. Thank you for having me here. I want to thank the Scleroderma Foundation for inviting me to speak. And I'm going to be in here for two sessions in a row, but the first talk I'm going to be giving is on pregnancy issues in scleroderma. So first I wanted to go over some definitions that I myself needed to remind myself about since I did OBGYN many years ago in medical school. But for the audience as well, I wanted to review some definitions regarding pregnancy. So a miscarriage is when the fetus dies in utero before 10 weeks of gestation, whereas fetal death is defined as fetus dying after 10 weeks of gestation. Intrauterine growth restriction is based on scales for gestational abdominal girth, and if the fetus has an abdominal girth less than the 5th percentile for gestational age, that's considered intrauterine growth restriction. Hypertensive disorders of pregnancy are defined as occurring after 20 weeks of gestation and can be defined in different categories. So gestational hypertension itself is any time you have a blood pressure of 140/90 or higher. Preeclampsia is defined as hypertension, that same level, 140/90 or higher, plus having protein in the urine. And then eclampsia is having preeclampsia plus having seizures as well. Premature rupture of membranes is the rupture of the amniotic sac before the onset of labor. And then prematurity is delivery of the infant less than 36 weeks of gestation, whereas severe prematurity is defined as giving birth prior to 34 weeks of gestation. Normal birth weight for an infant is between 2,700 and 4,000 grams, or 6 to 8.8 pounds. And if you're small for gestational age, that's less than the 10th percentile for age at birth. So also as more background, I want to talk a little bit about the pathology seen in the placenta in scleroderma pregnancies. So what happens, as you would expect, in scleroderma there's a lot of scar tissue or fibrosis that occurs in multiple organ systems, and this is no different for the placenta. So there's extensive fibrosis or scar tissue in and around the blood vessels. There's fibrosis or scar tissue of the placental tissue itself. And there's also presence of blood clots. And blood clots are even more likely to occur if the mother has the presence of antiphospholipid antibodies. You probably have heard about these antibodies, but antiphospholipid antibodies are seen in multiple different connective tissue diseases, probably most predominantly associated with lupus, but can be seen actually in the general population, 1 to 5% of the general population. And these antibodies can injure the blood vessel wall or the endothelial cell wall, which is the inner lining of the blood vessel, and also increase blood clotting risk. There are 3 different types of antiphospholipid antibodies, and any of them or multiple of them can be present in patients with systemic sclerosis. Anticardiolipin antibodies have been reported anywhere from 12 to 45% of patients to have this. Lupus anticoagulant, only about 4%. And beta-2 glycoprotein antibodies anywhere from 5 to 41%, depending on what cohort you're studying. All of these antibodies are associated with an increased risk for pregnancy complications, and those complications include early miscarriages, fetal death greater than 8 or 10 weeks of gestation, prematurity, and then hypertensive disorders such as preeclampsia and eclampsia. So here are photomicrographs of the histology seen in the placenta of a patient with scleroderma. Sorry, I can't find my pointer here. I can't seem to find my pointer on the screen, but over on the right-hand side is a scleroderma patient, and then on the left-hand side is the control. And you can see the inner lining of the blood vessel is basically filled with scar tissue in the scleroderma patient compared to the control. Likewise, in the middle panel, you can see all of that blue staining is related to fibrosis or scar tissue of the placenta tissue itself. And then finally, in the third panel, there's an insert showing with an arrow the blood clots that can develop within the placenta. So with all these problems affecting the placenta, the blood vessel and placental scarring, this leads to reduced blood flow to the fetus. So of course the fetus is at risk for problems including intrauterine growth restriction, prematurity, and being small for gestational age. So now I've given you some background on what is going on in the placenta and given you some definitions regarding pregnancy. And now I'm going to go more systematically through the issues that we have to deal with regarding pregnancy in patients with scleroderma. So I want to go through, first of all, the role of pregnancy in actually causing the disease itself. I want to review some of the issues regarding sexuality, fertility, the effects of pregnancy on scleroderma disease activity, pregnancy outcomes, pregnancy management, and the management of delivery. So you may have heard of the term microchimerism when people talk about what are things that are involved in causing scleroderma. Microchimerism is defined as a transfer of cells between a donor and a recipient, resulting in the presence of genetically foreign cells, and this can lead to an immune response in whoever's receiving those foreign cells. So the entity that epitomizes microchimerism is graft-versus-host disease after a stem cell transplant, where the donor actually has an immune response to the graft. So that the recipient actually has an immune response to the donor. So a similar issue is occurring whenever someone gets pregnant. So, and this can happen in the general population as well. There's a transfer of cells between the mother and fetus during pregnancy. And these cells can persist in the mother and fetus for many years afterwards, and even stay in the circulation in the mother when she subsequently gets pregnant again. And again, there's fetal maternal cell exchange in subsequent pregnancies, so the fetus can actually get fetal cells from the prior pregnancy. So with microchimerism, there's the cell transfer between the mother and the fetus. Then there's engraftment of those microchimeric cells in the host. And these microchimeric cells then have to actually be activated, and this could be by a virus or some chemical exposure, maybe even a cancer. And this subsequently leads to a graft-versus-host effect. And this immune response then affects various cells in the body, including the endothelial cells of the blood vessels, leading to activation of multiple inflammatory and fibrotic molecules, activation of immune cells themselves, and activation of fibroblasts, which leads to tissue fibrosis. So there's a lot of evidence supporting that microchimerism is actually involved in causing systemic sclerosis. I'm just going to read through this list here and then go through each variable and tell you a little bit more about the data that supports that microchimerism is involved in scleroderma. So first of all, scleroderma is more common in females, especially after childbearing age. So the epidemiology supports that microchimerism may have a role. Secondly, there are similarities between the disease graft-versus-host disease after stem cell transplant and systemic sclerosis. Thirdly, systemic sclerosis patients are more likely to have microchimeric cells in their blood and skin than healthy controls. There's an association between higher birth order, so being born later in terms of the number in your family, and the development of scleroderma later on in life. There's also an association with increased number of miscarriages and a later onset of systemic sclerosis. And finally, there's an increased likelihood of pregnancy complications in women who later develop systemic sclerosis. So first of all, graft-versus-host disease and systemic sclerosis, what do they have in common? So these are both diseases that affect the skin, the lung, the esophagus or GI tract, and involve scarring in both tissues, so the skin, the lungs, even the GI tract involved with scarring or fibrosis. There's also inflammation in these involved organs. And you can see in this picture here that this patient suffers from graft-versus-host disease involving the skin, and it looks very similar to patients with systemic sclerosis, even leading to such skin tightening that the patient has developed a contracture of the knee. Lastly, patients with graft-versus-host disease, up to a third of the time, can have autoantibodies that are consistent with systemic sclerosis. So there's a lot of overlap in these diseases. The second piece of evidence I wanted to review is the presence of microchimeric cells in patients with systemic sclerosis. These cells are detected in the blood of systemic sclerosis patients in 45 to 65% of cases, compared to only 5 to 35% of healthy controls. In addition, microchimeric cells are found in affected and unaffected skin of 20% of scleroderma patients compared to no controls. But there is a caveat that obviously not all patients have microchimeric cells in their blood or in their skin, so microchimerism alone is not leading to systemic sclerosis, but is just one component. Regarding birth order in systemic sclerosis, this is a study that looked at scleroderma cases and their unaffected siblings or controls. And basically, they found that as you increase your birth order, you increase the risk of developing systemic sclerosis or having systemic sclerosis. So if you were the second to the fifth child that was born, then you have a 25% increased risk of having scleroderma compared to your unaffected sibling. If you are between the sixth and ninth child born, you have more than a twofold risk. And if you're in a family that just has a ton of kids and you're in the 10th to 15th birth order, then you have a 3.5-fold increased risk of having scleroderma compared to a sibling. So overall, increased birth order is associated with an increased risk of development of scleroderma. And the thought is that maybe these microchimeric cells from prior pregnancies are increasing the risk to develop scleroderma in later pregnancies. Regarding prior miscarriages in systemic sclerosis, so this again looked at the scleroderma cases, this is the same study, compared to unaffected sisters. And if you had had at least one pregnancy loss, but at least one live birth, your risk of having scleroderma was a little bit more than 3-fold compared to the sister. Whereas if you had at least one pregnancy loss and no live births, your risk was 9.5 times higher. So the highest risk for development of scleroderma is if you have multiple miscarriages with no live births. And again, the theory is that maybe these microchimeric cells from prior pregnancies are increasing your risk for development of scleroderma. And finally, pregnancy complications in women occur more in patients who later develop scleroderma. So during pregnancy complications, there's increased movement of fetal cells into the mother's circulation, including during miscarriages and abortions, during pregnancy-induced hypertension, preeclampsia, intrauterine growth restriction, and in the syndrome called HELP syndrome, or hemolysis, elevated liver function, and low platelets. So this study looked at the pregnancy complications in women who later went on to develop systemic sclerosis. And they found that there was a much higher percentage of scleroderma patients who had prior pregnancy complications, including hypertension during pregnancy and intrauterine growth restriction, compared to controls. So about a 2.5-fold higher risk for hypertensive complications during pregnancy, and about a 4-fold increased risk for intrauterine growth restriction in those patients who later went on to develop scleroderma. So the question is, these pregnancy complications could be causing scleroderma by the transfer of more microchimeric cells due to the increased flow of fetal cells during these complications. Alternatively, it could be that these patients just really had early scleroderma and already had the effects of fibrosis on their blood vessels and in the placenta, and they were bound to develop scleroderma regardless of the microchimerism. So there are two theories that could be supported by this data. So now that I've reviewed the microchimerism role in pregnancy, I'm going to move on and briefly talk about sexuality and systemic sclerosis. So there was a large survey done that found that 60% of scleroderma patients are still sexually active. So that's pretty good. However, these patients reported multiple physical limitations that affect their sexuality, including a large percentage complaining of fatigue, body pain, more than 40% complaining of vaginal dryness, pain with intercourse, and difficulty with hands and decreased oral aperture affecting sexuality. So hand pain from contractures, digital ulcers, Raynaud's, and arthritis. In addition, there's a mental or emotional impact of the disease on sexuality in scleroderma. Patients are dissatisfied with their body image, their appearance, and their body form. And they're depressed, so their libido can often be decreased due to this. In terms of fertility in scleroderma, we already touched a bit on the fact that patients who have prior miscarriages are more likely to develop scleroderma. And in this other study, scleroderma patients were found to have twice the rate of miscarriages and 3 times the rate of infertility compared with control patients before the onset of scleroderma. Again, could these patients have already had scleroderma in early form while they're pregnant, or is it due to the microchimerism increasing the risk of onset of scleroderma? Interestingly, the rate of miscarriages is not significantly different in established scleroderma compared with controls. So once you actually have scleroderma, your risk of having more miscarriages is not necessarily higher. However, if you do have diffuse cutaneous disease, the rate of miscarriages was higher than if you had limited skin involvement. This was a study done by Dr. Steen in 1999, and she looked at 214 patients with systemic sclerosis, 167 with rheumatoid arthritis, and 105 normal controls. She did find that patients with systemic sclerosis and rheumatoid arthritis were more likely to never be pregnant compared with healthy controls, whether that's because they were older or they were concerned for effects of pregnancy on their disease. That's unclear. However, if you look at the number of or percentage of patients who were unable to ever become pregnant, even though they tried and were unsuccessful, and those who were unable to become pregnant for a year or more, it's actually similar across the groups. And finally, the overall success rate, which is here on the bottom of the table, shows that 37% of scleroderma patients were actually able to become pregnant, compared to 40% of RA patients and 43% of normal controls, so not significantly different. Looking at the effects of pregnancy on systemic sclerosis, it's sometimes hard to tease out because symptoms you develop in pregnancy normally can mimic those symptoms of scleroderma frequently. Most studies show that there's no significant changes in scleroderma disease status during pregnancy, and this is in contrast to studies of lupus patients who often have disease flares during pregnancy. One study found that maternal skin disease was stable in the majority of scleroderma pregnancies, in about 60% of these patients. It actually improved in 20% and worsened in only about 20%. So the patients who were at highest risk for worsening of skin involvement were those early diffuse patients. Whether the pregnancy actually impacted the worsening of skin disease or they were bound to have worsening skin disease regardless of their pregnancy is unclear. Renal crisis is the cause of the most scleroderma-related maternal deaths during pregnancy. So this is definitely a very serious condition, and patients should not get pregnant if they have renal crisis. Sometimes, again, it's hard to tease out between the presence of renal crisis and the pregnancy complications like preeclampsia or eclampsia. In total, we basically want to avoid pregnancy in early diffuse systemic sclerosis patients because that's when their risk for renal crisis is the highest. So looking at other effects of pregnancy on systemic sclerosis, we already talked about the fact that overall the disease is generally stable. Raynaud's phenomenon actually improves during pregnancy because of the vasodilatation that occurs. throughout the body. However, after or during complicated deliveries, the Raynaud's can actually worsen when you're clamping down your blood vessels. We talked about the skin and how some patients can worsen, but most patients are stable. In terms of the joints, there are typically more arthralgias during pregnancy, and this is similar to non-scleroderma pregnancies. In terms of gastrointestinal involvement, the reflux can worsen, again, just like non-scleroderma patients. In terms of cardiopulmonary status, the shortness of breath from scleroderma problems can be aggravated, just as in other diseases. When you are gravid, you have a smaller capacity for your breathing, but certainly symptoms of shortness of breath can worsen. Also, anemia comes into play here. And again, we talked about renal crisis and the fact that early diffuse scleroderma patients are at highest risk for renal crisis despite pregnancy. Regarding pregnancy outcomes in systemic sclerosis, so overall 90% of scleroderma pregnancies actually result in live births, so that's a very good statistic. However, most studies indicate that there is an increased risk for multiple complications, and we've touched a bit on these already, but intrauterine growth restriction, prematurity, low birth weight, hypertensive disorders of pregnancy, and cesarean sections. So I'm going to go through the data of each of these. So regarding intrauterine growth restriction in scleroderma pregnancies, again, this is defined as having a fetal abdominal girth less than the 5th percentile for gestational age. About 5% of scleroderma pregnancies in the US are associated with intrauterine growth restriction. However, only 1.7% of controls will have this problem, and about 2.5% of patients with idiopathic pulmonary arterial hypertension, which is a disease that also has vascular injury, but predominantly affecting the pulmonary blood vessels. And actually 6% of sickle cell disease, again, another disease associated with vascular problems and blood clotting. So overall, there's a 3.7 to 4.4 times higher risk for intrauterine growth restriction in systemic sclerosis patients compared with controls. Regarding prematurity in scleroderma patients, again, prematurity is defined as delivery at less than 37 weeks, severe prematurity, delivery at less than 34 weeks. And it's been reported in 12 to 40% of scleroderma pregnancies. However, the mean delivery for premature infants is 35 weeks, so not much shorter than 37 weeks. A study looking at 133 scleroderma pregnancies compared to 134 rheumatoid arthritis pregnancies and 158 normal controls found that prematurity was higher in the scleroderma and rheumatoid arthritis patients compared to the controls. Looking at a different study of 91 scleroderma pregnancies compared to 158 controls, the risk for prematurity was almost threefold higher in scleroderma patients. So this has been replicated. It does seem that it's more frequent than in healthy controls. So what are risk factors associated with leading to prematurity in patients with systemic sclerosis? Shown in green are those risk factors that actually increase the onset or the risk for prematurity, while those in red actually decrease the risk for prematurity in scleroderma pregnancies. So we look mostly at the multivariate analyses. This is correcting for age and other factors that can affect prematurity rates. And corticosteroids, the use of these steroid medications actually increase the risk for prematurity by more than 3.5-fold. So that's telling us we really should keep away from steroids if we can during pregnancy. The use of folic acid actually decreased the risk for prematurity by 70%. And interestingly, being SCL70 positive decreased the risk for prematurity by 74%. So that's a difficult one to explain, actually. In terms of low birth weight in scleroderma patients, scleroderma pregnancies, the fetus can be either small, full-term birth at less than 2,500 grams or 5.5 pounds, or they can be very low birth weight, less than 1,500 grams or 3.3 pounds, so very tiny. And problems with low birth weight is associated with 10 to 50% of scleroderma pregnancies. And it's more frequent in scleroderma compared to rheumatoid arthritis and normal controls. There's almost a 5-fold higher likelihood to have a very low birth weight baby in scleroderma patients than controls. And then finally, fetal death in scleroderma pregnancies. Again, this is when the fetus dies after 10 weeks of gestation. Interestingly, fetal deaths are actually pretty rare in scleroderma patients, so it seems like if you can get through the early part of pregnancy, that the fetus will actually survive, though they may be a lot smaller or premature. So there are similar rates to normal controls. And typically, the occurrence of fetal death is in those patients who have very severe diffuse scleroderma, and it's often related to development of scleroderma renal crisis. Hypertension in scleroderma pregnancy. I already went over the definitions of hypertensive disorders of pregnancy occurring at greater than 20 weeks of gestation. So that you can develop gestational hypertension, preeclampsia with the addition of proteinuria, or eclampsia with the addition of seizures. So why would scleroderma patients be at risk for hypertensive disorders of pregnancy? So here are photomicrographs of the blood vessels in scleroderma patients, one in a patient with scleroderma renal crisis on the right, and on the left showing a scleroderma digital artery. And basically what you can see in both cases is that there's this onion skinning pattern with a decrease in the size of the blood vessel opening. So this same scarring process is likely occurring, affecting the placenta and the kidney blood vessels during the time of pregnancy in scleroderma patients. So almost a quarter of scleroderma pregnancies in the US are complicated by hypertensive disorders. This compares to only about 8% in controls versus other disease controls, 34% in idiopathic PAH and 19% in sickle cell disease. So there's a 4-fold increased risk compared with the general US population. What's interesting is that there is an effect on where the study is performed. In Italy, it was found that there was no difference in hypertensive disorders of pregnancy in scleroderma versus controls. And whether that's because they do screening for blood pressure problems and institute treatment earlier, it's unclear. Regarding cesarean sections, these are more common in patients with scleroderma compared to the general population, both in the US and in Italy. So 42 to 52% of scleroderma deliveries are delivered by C-section, compared to 31% in the general US and Italian populations. So in general, there's a 1.4 to 2.4 times more likelihood to undergo a C-section if you have scleroderma than if you're in the general population. And this could be related to the actual increased risk for complications, or it could just be a perceived risk by the patient and the physician that they want to avoid complications with vaginal delivery. So patients with scleroderma are slightly older at conception, 30 compared to 27 in the general population, the mean age for pregnancies. However, that age difference could be playing a role in why physicians decide that they want to do a C-section rather than vaginal birth in scleroderma patients. So overall, pregnancy management in scleroderma is a multidisciplinary effort, and certainly your rheumatologist should be involved, high-risk OB should be involved, and various other consultants such as pulmonary, GI, cardiology, dermatology, or renal may need to be involved, depending on what organ involvement you develop. So it's important that your doctor does an early evaluation for the extent of scleroderma organ involvement prior to conceiving, and also evaluates your autoantibody status for a risk assessment during pregnancy. So in terms of organ assessment prior to conception, your doctor should be evaluating your lungs. Your doctor should be getting pulmonary function tests as well as a cardiac echo. If they suspect pulmonary hypertension, they should be doing a right heart catheterization before conception. And if you do have pulmonary hypertension, you really should avoid pregnancy, certainly in moderate to severe cases. And it's a case-by-case decision in milder cases of pulmonary hypertension. Regarding interstitial lung disease, similarly, if you have moderate to severe interstitial lung disease, it's probably not a good time to get pregnant. But in milder cases, you may be okay in terms of your breathing status. Regarding evaluating heart involvement, you want to evaluate for congestive heart failure with a cardiac echo, conduction blocks with an EKG. Again, if congestive heart failure is moderate to severe, you should avoid pregnancy. If it's mild, you probably will be okay. Renal crisis should be evaluated with blood pressure, urinalysis, blood tests, including the serum creatinine and your blood counts. And if you do have renal crisis, you should certainly avoid pregnancy. And you could reconsider becoming pregnant once your creatinine and your kidney function has stabilized. If you develop renal crisis during pregnancy, you should still be treated with ACE inhibitors, despite the effect on the fetus. Regarding skin involvement, we use a modified Rodnan skin score to assess how severe your skin is. And prior to pregnancy, basically the main issue is if you're having rapidly progressive skin tightening, that's probably not the time to get pregnant. Regarding GI symptoms, you want to assess the degree of reflux. You also may need an endoscopy, looking for any source of bleeding if you have iron deficiency, and to assess how bad your reflux is. You want to optimize antacid therapy before becoming pregnant. And finally, digital ulcers. This could be a marker of having more vascular disease, so a potential risk factor for hypertensive problems during pregnancy. However, the ulcers tend to improve just like Raynaud's phenomenon improves during pregnancy, but may worsen afterwards. Regarding autoantibodies, so there are a couple of autoantibodies that are associated with diffuse skin involvement that if you are positive for these antibodies and you're early in your disease, you're probably at a little bit of a higher risk for developing a renal crisis. Particularly patients who are anti-RNA polymerase III positive, they're at a higher risk for developing a renal crisis and certainly should avoid pregnancy during early disease. For anti-SCL70 antibodies, that's also associated with diffuse skin involvement, and if you're rapidly progressing in terms of your skin tightening, again, that's probably not a good time to get pregnant. The anti-centromere antibody is associated with pulmonary hypertension, and so assessment with a cardiac echo and potentially a right heart catheterization should be done prior to conception. The anti-Rho and anti-LA antibodies are associated with fetal heart block. These antibodies can be seen in other connective tissue diseases like lupus and dermatomyositis as well, and even in the healthy general population. But they're associated with a risk for fetal heart block, and therefore the fetal heart rate has to be monitored bi-weekly from 16 weeks of gestation onwards. And finally, we talked about the antiphospholipid antibodies. All scleroderma patients who are thinking about becoming pregnant or who are pregnant should have these antibodies tested for. They're associated with increased risk for pulmonary hypertension, macrovascular or blood vessel problems, as well as possible recurrent abortions. So in these patients, you may actually need to use low molecular weight heparin if they have these antibodies in their bloodstream. So in summary, here are some points regarding pregnancy management in scleroderma patients. So I've touched on this multiple times, but again, I'll say that pregnancy should be avoided in early and or progressive diffuse cutaneous skin disease. Medications that may be harmful to the fetus need to be discontinued, things like D-penicillamine, methotrexate, Cellcept, cyclophosphamide. You want to minimize use of proton pump inhibitors and calcium channel blockers, but certainly these agents are okay to use if your reflux or your Raynaud's is very severe during pregnancy. You want to avoid corticosteroids if you can. Again, we saw that association with prematurity. And you want to frequently monitor the mom's blood pressure. Also, you want to monitor for protein in the urine, which the OBGYNs do very routinely during the OB visits. And you want to have frequent monitoring of the fetal size and for uterine contractions, looking for any evidence of prematurity or small for gestational birth. So in terms of treatment of hypertension, as I mentioned, ACE inhibitors are absolutely necessary for the treatment of renal crisis despite the effects on the fetus. And regarding preeclampsia, the actual mode of treatment is to deliver. If you can get the fetus to be developed enough and safe enough for the fetus to be delivered, that will actually heal the preeclampsia in the mother. Finally, close observation and treatment of premature labor in scleroderma patients is very important. So how about when you're actually delivering the child? So if there's no fetal distress, no lung, heart, or kidney problems, or severe contractures in the mother, a vaginal birth actually should be preferred rather than going through a C-section and surgery. So this is actually going against the data that we see that more physicians and patients choose to do C-sections than vaginal deliveries. But really the vaginal deliveries, unless you have these other issues, should be preferred. You want to make sure that you have IV access before delivery in case any problems occur. Sometimes this is hard in patients with very tight skin over the areas of their blood vessels. Epidural anesthesia is preferred. And you want to make sure, just like we have all these blankets in our rooms here during the conferences, that there are lots of blankets, warming fluids, warm IV fluids to give to the patient after delivery. In addition, because sometimes scleroderma patients have difficulty with wound healing, you want to give careful attention to any episiotomy that's necessary or C-section incisions. Postpartum, you want to monitor the patients very closely. You want to reinstitute their medications that you stopped, and you want to aggressively treat hypertension and monitor for persistent hypertension after the patient delivers. So in summary, the majority of pregnancies are actually uneventful in systemic sclerosis patients, and 90% of pregnancies actually result in live births. The blood vessel problems can occur in scleroderma patients, affecting the placenta as well as the mother, leading to complications during pregnancy. Prior pregnancy and pregnancy complications actually could be a risk factor for the later development of systemic sclerosis. And scleroderma symptoms are generally easily managed in pregnancy, except in, again, those cases who have early progressive disease at conception. Pregnancy complications are definitely more common in scleroderma than the general population, but despite that, can still result in healthy children. And close monitoring with a rheumatologist, high-risk OB, as well as other consultants is necessary before, during, and after pregnancy. So I just wanted to thank my colleagues at the Stanford Scleroderma Center, David Fiorentino, who's a dermatologist who leads the scleroderma clinic with me, as well as my pulmonary and GI colleagues. And I would like to thank the Scleroderma Foundation and also the Scleroderma Research Foundation, who supports our center.